Well, good afternoon, good morning, hello to all of our GME. My name is Dr. Asia McCleary-Gaddy, and I am the Director of Diversity and Inclusion for our wonderful UT Health Science Center. I'm also an Assistant Professor of Psychiatry from McGovern Medical School. And today I have the honor of talking to you all about implicit bias in medicine. As you can see, I am a PhD, not an MD, and so I'm grounded in research, specifically experimental social psychology. So I'm really excited to talk to you all today about implicit bias because its beginnings are in social psychology. But first, I want to orient you all to the Office of Diversity and Inclusion. We are led by none other than our Executive Vice President for Student Affairs and Diversity, Dr. Latanya Love, our Assistant Dean of Diversity and Inclusion, Dr. Pedro Mancias, myself, the Director of Diversity and Inclusion, Dr. Asia McCleary-Gaddy, and of course, our Program Manager, Luna Hornsby, and our very new addition Program Coordinator, Jennifer Ramos. If you have any questions or concerns, please reach out to any of us at any time, and we are more than happy to respond to you all. We pride ourselves on being prompt in response. Now, today we're going to discuss what is implicit bias and why it matters. We're going to describe how implicit bias creates a barrier to equitable health and hiring practices. And then last, we're going to identify strategies used to mitigate implicit bias. So kind of go through the who, what, where, why, and when. But before I start any of my presentations, I always like to begin with the McGovern Medical School mission. Our mission is to educate a diverse body of future physicians and biomedical scientists for a career dedicated to the highest ideals of their profession, to provide outstanding patient-centered care, and to conduct innovative research that benefits the health and well-being of the population of Texas and beyond. And so as you can see from our mission, there are a few phrases that are underlined: diverse body, highest ideals of the profession, health and well-being of the population of Texas and beyond. We talk about implicit bias, we talk about diversity, equity, and inclusion because it is a standard of excellence for McGovern Medical School. It's embedded in our mission. So today, I hope you all, with the time that I am given, listen and apply this in your day-to-day because implicit bias is integral to providing outstanding care, outstanding quality of care, and also to the well-being of our medical school. So without further ado, let us begin. Implicit bias or unconscious bias, as you can see, you can use those terms synonymously, is an unintentional, subliminal belief or attitude that affects our understanding, actions, and decisions in an unconscious way. So as you can see, again, there are a few terms that are underlined. The first is unintentional or unconscious, meaning that implicit bias kind of happens automatically. I don't mean to have these things. I'm not doing it on purpose. And the next terms that are underlined are belief or attitude. And I always want to highlight this because a lot of people believe that implicit bias is the same as discrimination. That is not true. Implicit bias is a belief or attitude. It's more a cognition. Discrimination is a behavior. Now, we study implicit bias because if I have a biased attitude, I most likely will have a biased behavior. But we also study implicit bias because they're what we call malleable, meaning that we can change them. We can unlearn our implicit biases. So again, to differentiate, a lot of times implicit bias, stereotypes, discrimination are all said synonymously, but they are very different. They actually build off one another. So implicit bias are unconscious bias thoughts. But when we turn the unconscious into conscious, we get into our stereotypes. Stereotypes are also these associations that we have with certain groups, but we're conscious, we're aware of those associations. And then discrimination is the biased behavior that comes out of these things, okay? So if these things are happening automatically without me purposefully doing it, why do we have them in the first place? The answer is very simple. At any given time as human beings, we are bombarded with a bunch of stimuli. And with that stimuli, we have to make a quick decision. So to process that information more efficiently, our brain uses shortcuts where they find connections to pieces of information. And so implicit biases serve a functional role in our lives. And when I think about implicit biases, I think about the classic movie, Disney movie, The Little Mermaid. And it's that scene where she is sitting at a table, there is a plate, there is a knife, and there is a fork. And she does not have the association that perhaps this utensil is used to eat. And since she doesn't have that association, she picks up the fork and starts raking through her hair, using it as a comb. So this is an example of if you don't have that information, that quick association, we will constantly be questioning everything. For example, picking up this pen and saying, what? It's not a pen. Perhaps it's a way for me to scratch my face. Perhaps it's a way for me to curl my hair. Perhaps it's a way for me to scratch. All of those different things. Now, the implicit association task has gained a lot of popularity when talking about implicit bias. And the implicit association task, or IAT, simply measures how fast you can make an association. So, for example, on the left-hand side of the screen, you see the word fun, and underneath it is a picture of a coconut tree, clear waters, white sand. And on the right-hand side of the screen is the word fear, with a shark, sharp teeth, deep water. Now, one would hypothesize that it is easier to associate the word fun with images of a coconut tree, clear waters, white sand, and it is easier to associate the word fear with a shark, sharp teeth, deep water. Now, if we were to switch those labels such that now fun is associated with the shark and fear is now associated with the coconut tree, it would take us a little bit longer to come and make that quick association. Now, in reality, we are more likely to be injured by a wobbly coconut than we are to be bitten by a shark. However, through society and what we are taught, we have learned to be more fearful of the shark than we are of that wobbly coconut on the tree. So here is an example of a real image from an IAT. On the left-hand side of the screen, you see the word female in career, and on the right-hand side of the screen is the word male and family. Now, in the center of the screen is the word salary. Salary is a term that is associated with the word career, and so you would click a key that is associated with the left-hand side of the screen. And you're doing this as fast as you can. Now, eventually, as you move on through the IAT, the labels will switch such that male is now associated with career and female is now associated with family. So again, it is trying to measure, is it easier for this person to associate females with career and males with family, or vice versa? Here is another example of an IAT, and this is the race IAT, and it shows you exactly how it changes. The IAT uses images and it uses words. So if we take box A, we see that black patient or bad word on the left, white patient or good word on the right-hand side. In A, we see an image of a black person, so you would click the key on the left-hand side of the screen. In box B, we see that they use words. Pleasure. Pleasure is a good or positive word, so you would click the right-hand side of the screen that is associated with a white patient or good. Now, as you can see from our bottom boxes, C and D, eventually the labels switch such that white patients are now associated with bad and black patients are associated with good. And again, you're making those associations with the keys on your laptop or board or phone or what have you. And then again, it is using words. Now, you can take an implicit bias test for free at Project Implicit that is housed at Harvard University. They have a bunch of IATs that look at race, disability, sexual orientation, family, career, even down to presidents. And so I encourage you all to take an IAT and see where your implicit biases lie. But now that we've discussed what an implicit bias is, why do we have implicit biases, and how do we measure implicit biases, now I want to talk about the implications of implicit bias and race. So in this study done by Hoffman and colleagues in 2016, they looked at the biological false beliefs about biological differences between African Americans and whites. So as you can see listed, these are some of the false beliefs. Blacks age more slowly than whites. Black people's blood coagulates more quickly than whites. Black nerve endings are less sensitive than whites. All of these are false. However, they used medical students, residents, and lay people as their participants. And if we follow the first row, we see that for Blacks age more slowly than whites, we see that 21 out of 63 first-year medical students believe this to be true. It's just about at 30%. By second year, it was 28 out of 72. Again, around that 30% mark. But as you can see, by the time we hit residency, 14 out of the 28 residents believed that Blacks age more slowly than whites. That's 50%. So this study was important and made a big splash within the field. One, because it was just conducted, or I should say published, in 2016. So this is recent data. Second, if we are not explicitly teaching this within our medical schools, how do our medical students believe this to be true? And then third, as I discussed earlier, if we have a biased belief, how does that translate into our actions? And so this opens up a greater conversation around health inequities and disparities. Across their study, they found that 73% of lay white people who are not in medicine endorsed at least one untrue biological difference. But within medical students and residents, 50% endorsed at least one false biological difference. In another study done by Schwartz and colleagues in 2003, which was also done with health professionals, medical, nursing, and dentistry, they took the weight IAT. And specifically for this study, as you can see, we have our images and words. But in this study, instead of using bad words such as agony, terrible, and horrible, they used negative stereotypes associated with those who are overweight. So lazy, stupid, worthless. And what they found is that the health professionals who completed this IAT exercise showed a significant pro-thin bias. So in other words, it was easier for the health professionals to associate that larger silhouette with words such as worthless, stupid, and lazy than it was for them to associate that with thin people. Again, a biased thought. How does that translate into action? But moving outside of patient care, we also look at implicit bias and how that affects our hiring decisions. And so in this study done at Yale University by Corinne Moss-Rockerson, she did what is called a resume study. In a resume study, you have two resumes with almost identical information. You only change one aspect of that resume. In this study, the one aspect that she changed was the name to be either more female sounding or male sounding. So a Michael versus a Michelle, a Jane Doe versus a John Doe. The rest of the information on the resume was pretty much the same. And she sent these resumes out to real research-intensive universities who were looking for a lab manager position. And what they found is that the male resume or student was seen to have more would receive more mentoring experience, was more likely to be hired, and was seen as more competent. And so this study highlighted a lot within our field, because when we talk about the lack of women in STEM, it may not be a matter of that woman is not qualified. In this study, she showed that two equally qualified individuals have very different outcomes depending on their sex or gender. And so when we talk about the lack of women in medicine and STEM, people turn to implicit biases and how that can be a way to host other people out of certain opportunities. Again, looking at workplace differences, we also see a difference in letters of recommendation written for women versus men. And so overall, women are more likely to receive shorter letters than men are. Their accomplishments are perceived as a team effort versus an individual effort. And women are described in more stereotypical terms such as caring and compassionate versus male terms such as successful and accomplished. Now, in regards to discrimination or harassment, here at McGovern and across UT Health, we do have HOOP policy number 183, non-discrimination, anti-harassment, and equal opportunity, which states that or prohibits discrimination and or harassment by any member of the university community on any basis prohibited by law or policy. So if by any means you have experienced or you think you will experience, it's important that we know our reporting options. So we have three here, and I think you all are familiar with this slide from your prior presentation, but I wanted to bring this up again, that you do have multiple reporting options, including anonymously. Now that we spoke kind of about the who, what, where, why, when, and why it's important to talk about implicit bias within our health field, I now want to end off with strategies to reduce implicit bias. Leaders in our field believe that there is no way for us to completely get rid of our implicit biases because they are so pervasive. Scientists have found that as young as 3 months old, our babies are able to mimic the implicit biases of their parents. And so we do not believe we can completely get rid of our implicit biases, but we can mitigate them or reduce them. And there have been 5 strategies that have been researched to mitigate implicit bias. The first is awareness or concern. Being aware of where your implicit biases are and concerned to make a change about them. Next is counter-stereotyping, going against the stereotype. Remember, the difference between an implicit bias and a stereotype is that one is unconscious and the other is conscious. Next is individuation, looking at each person as an individual versus an exemplar of a group. Perspective taking, imagining what it must be like to be in that person's shoes. And then last but not least is intergroup contact, making contact with an individual for your own versus listening to it secondhand. So first, counter stereotyping, opposite of this stereotype. I have on the left-hand side of the screen, it's a stereotype, but yes, my Asian parents wanted me to go into medicine. I usually bring up this story of the University of Massachusetts Amherst, a psychology professor who took the IAT looking at Asians in math, and she found that she does have a strong implicit bias that Asians are just very good at math. And so what she did was look at counter stereotypes, opposite of this stereotype. And so on the right-hand side of the screen, I have a picture of Jeremy Lin, who's a very successful basketball player. And so what this professor did was on the back of her phone, on her laptop, around her office, where she spends a lot of her time, she placed different images of counter stereotypes. And so in this case, that would be Asians that are good at things or great at things that are outside of math. Counter stereotype, opposite of the stereotype. And so a few months of repeated exposure to these counter stereotypes, the professor then took the IAT again and found that her results were less. Her bias had been less. Counter stereotyping. Next is awareness, figuring out where our implicit biases lie. And so in this study done by Quinn Capers, they looked at Ohio State University's College of Medicine, and it was done with their admissions committee. And what they did for their admissions committee is have them all take the Black-White Implicit Association task. And what they found is that the majority of their admissions committee showed an implicit white bias. So in other words, they were more likely to choose a white student over a Black student. Now, 50% or approximately 50% were conscious of their individual IAT results when interviewing candidates for the next cycle. And what happened is that the class that matriculated following the IAT exercise was the most diverse class in that College of Medicine's history at that time. So again, being conscious of where your biases are, you're thinking more effortfully about the decisions that you make. And so you just thinking twice or deeper about your decisions actually led to a more diverse class for that school of medicine. Next is perspective taking. And this study was done with nursing professionals. And in the study, they asked nursing professionals to watch real videos of Black and white patients experiencing pain. And they were tasked with giving that patient a pain treatment. Now, when the nursing professionals were asked to give this pain treatment, we see the bars to the left, which mimic what we see in society. White patients received a higher pain treatment than Black patients. However, when they asked a different group of nursing professionals to watch the real videos of Black and white patients experiencing pain, but now imagine how that patient's pain affects their lives. Imagine how that pain affects their day-to-day interactions. Now provide a pain treatment. We see the bars on the right-hand side of our screen. Now, as we can see, white patients still received a higher pain treatment than Black patients. However, we see a 55% reduction in the pain treatment bias. So what I love about this study is that doing something simple as imagining how that pain affects a person's life makes such a dramatic difference. Again, using these techniques does not completely get rid of all your biases. We still see that there is a difference based on race. However, we also see that there is a 55% reduction. So when we talk about the health inequities and disparities across the nation, we want to also talk about strategies that can possibly reduce them, such as perspective taking. And then last but not least is the contact. And so in that same study I had mentioned earlier about the health professionals who showed a weight bias, they also found that if the health professional was somebody who was heavier weight or had a close friend who was overweight, they were less likely to show that pro-thin bias. So in other words, if I'm a person that is overweight and I don't think of myself as lazy, stupid, or worthless, or I have a close friend who is overweight and I don't think that they're lazy, stupid, or worthless, I may not show that on my IAT because I do not have that association. So here at McGovern, we understand that patients will show their implicit biases toward their healthcare professionals, but it can also go the other way around. And so we also implement the ERACE framework. where our supervising physicians should follow this acronym. E for expect that mistreatment will happen. R, recognize when mistreatment occurs. A, address the situation in real time. S, support the trainee after the event. And E, establish a positive culture. So again, for our strategies, we have perspective taking, imagine what it must be like, awareness/concern, taking an IET, figuring out where your bias is, and concern to make a change, counter stereotyping, going against the stereotype, the conscious associations that you have, individuation, looking at each person as an individual, and then last, intergroup contact, those positive, making those knowledgeable things for yourself versus listening to someone else. Alrighty? And again, I want to leave you all with reporting options. In the event that something is to happen, you have 3 different reporting options. Again, even though it's not on the slide, the Office of Diversity and Inclusion is also a reporting option. Feel free to reach out to any of us at any time with any concerns. We are more than happy to help you all. So again, I thank you for your time. If you have any questions about today's presentation, feel free to reach out to me. Again, my name is Dr. Asia McCleary-Gaddy. I'm the Director of Diversity and Inclusion, as well as Assistant Professor of McGovern Medical School. You all have a phenomenal day.